Okay, so I think these are familiar faces here. So they probably know about the HRSA grant, and I'd just like to remind, this is one of the funded activities from our HRSA grant. And the focus this year has been, the cycle has been on telemedicine. So I'm totally excited to hear the experience from Mississippi, because Dr. Kirmse had done his training in telemedicine at National Children's as a fellow before he came to Mississippi, and really is a pioneer. So I will let Teresa introduce him before he starts. So.
Good afternoon, everybody. So we have Dr. Kirmse joining us today from the University of Mississippi Medical Center. And so he started off first as a metabolic telehealth provider in 2014 while he was based at Children's National in Washington, D.C. And then he moved to Mississippi in 2015, where he is currently working as a geneticist and biochemical and metabolic geneticist and genetics. And so you will be presenting today on access to clinical genetic services in Mississippi.
Yeah.
Take it away.
Yeah, I do want to add a comment though. Dr. Kirmse did offer services to Mississippi from National Children's for a while before he actually came there. Am I correct about that?
Yeah, for a whole year. I'll talk about that.
Wonderful.
Yeah.
Fantastic. So, and I want to welcome all of our other states in the region who have dialed in. I'm excited for the turnout, for the people who have dialed in today to listen to you. So we'll let you get started. Thank you.
Wonderful. Well, I just want to thank all of you for coming today, and for Ronnie and Teresa for inviting me to give this talk. This is a new talk for me. I've not given this talk anywhere, so I put it together for this purpose. But also, it's been fun because I think I could probably take this talk on the road, because I think putting it together snapped into focus kind of the last 2 years of my life and what we've actually accomplished using technology to improve access to clinical genetic services in the state of Mississippi. The talk is going to be mostly narrative with, so it's hopefully won't be too boring. Hopefully I'll tell a story about the last 2 years that kind of gives you an idea of some of the barriers that we've come up against, which I'm sure are barriers that everybody in the room has encountered if you're using telemedicine to provide clinical care, and hopefully some solutions that we've come up with that might translate and be generalizable to other situations. So anyway, I'm going to stop my video so you don't have to look at my face, and hopefully the audio clearer, but I'll keep looking at you guys just in case there's any problems. Well, I'll look to you to let me know. Great. So this was the team here in Mississippi, the genetics team, in 2014 when I started working with them. So the way the story goes is that George Bach, the metabolic geneticist or biochemical geneticist here in Mississippi, decided to retire in 2014 in the summer. And while they had genetic services here, they didn't have any biochemical geneticists. And so the then chair of pediatrics, Rick Barr, called Children's National, essentially, and asked them if there was any way that they could lend support to their newborn screening and biochemical genetics program. At the time, I was in DC. I was actually junior faculty there and working on a completely unrelated grant for metabolic disorders and HIV, actually, of all things, not anything to do with telemedicine, but I was dabbling in telemedicine and actually providing some services to the Eastern Shore of Maryland. So I was the kind of the go-to geneticist for telemedicine at that time. So Marshall Summer, my chair over at Children's National, said, "Well, does this sound like something you'd like to do?" And I said, "Yeah, it sounds fun." So so that's what I did. That's me in the center there, the telemetabolic geneticist. I did that for a year with all these folks, and and see if my little pointer actually works. But Jennifer Cook here, can you see the? Oops.
That's smiley faces.
Yeah. Do you see? do you see the arrow, guys?
Yes.
So this is Jennifer Cook, and this is Leslie Berryhill, and this is NP in Mississippi and RD in Mississippi who helped with this model while I lived in Washington, D.C. for that last year. Anyway, I'll cut to the chase, and I was impressed enough with the Center for Telehealth and with the team in Mississippi. And my wife is a parasitologist, and she was given the opportunity to continue her research in sub-Saharan Africa with some from NIH. So we decided to take the plunge and move to Mississippi, and I was going to do telehealth and work on my projects, and she was going to work on hers. So, and for the first year we were here, that's pretty much how it worked, and it was a great situation. But in the summer of 2017, and you've already seen the punchline, but over a period of 4 months, a lot of the team left Mississippi for various reasons. All good reasons, mostly for professional and personal growth, but it all happened very quickly. And so we lost 3 geneticists and several genetic counselors to other opportunities, plus my nurse practitioner and dietitian. So it was a bit of a crisis. A couple of genetic counselors left, and this is, of course, Emily Booth, who a lot of you know, who's worked with me on the telehealth aspects of our program, and Laura Hendon, the prenatal genetic counselor here, and Becky Morgan, who's been here longer than any of us, is our administrator. So we kind of pulled our bootstraps up and asked the question, how do we take care of everybody with, you know, a fraction of the providers that that we had? So the question became, do we just go the traditional model? And I actually don't know my audience too well today. I apologize, but I don't know how you guys do it in Atlanta, but a lot of the traditional model of clinical genetic services kind of, and we're not talking just metabolic here, we're just talking about, you know, when counselors and geneticists left here, kind of left with all comers to genetic clinic, not just the metabolic patients. So the traditional model is physician counselor dyads, you know, in the hierarchies that are usually or traditionally there. And that was going to be difficult because we had 2 counselors and just 1 geneticist. And didn't, you know, plus my full-time job was taking care of the metabolic patients, of which we have plenty in Mississippi to take care of. So, you know, we were also worried that that those of us who were left were going to, you know, succumb to what a lot of us are feeling these days in clinical medicine, which is burnout, you know, survivor burnout in this particular case. So then, you know, I started to think of ways that we could use our strengths and, you know, here in Mississippi to actually change the models in the way that we provide care. So hopefully the rest of this talk is going to be focused on, you know, what those barriers were, some of those barriers, and how we've overcome them. So just a little background on Mississippi, because I didn't know much about this state before I moved here. So, and most people don't. Most people know what they're told about Mississippi, and most people know, you know, some of the difficult past of Mississippi, you know, and to be honest, my impression of Mississippi was just what I'd seen in the movies and what I'd heard from people who thought they knew about the Deep South. But you guys being in Atlanta, you know, probably heard some of those things. But Mississippi, as every place, is a very interesting and diverse place with, you know, lots of people with genetic disorders. So we'll dive right in. There's about 3 million residents in the state of Mississippi. It's the 32nd most populous state in the union. It's also happens to be the 32nd most population dense state. So it's not very dense. There's about 63 people per square mile. It's not the most rural state in the union, but it's not, it's not a very, what we would consider an urban state at all. And just for those of you who have not visited here, it's basically, this is, a political map, I guess, of Mississippi. The state is transected by two interstate highways, the I-55, which goes basically north and south from Chicago down to New Orleans, and the Highway 20, which goes all the way to Atlanta. It's what connects us, and goes all the way to Texas as well, Dallas, I believe. And most of the population is in the Jackson metropolitan area. I should say a large chunk of the population. And the other two urban centers are Biloxi on the coast and Hattiesburg is another big population center, which is between Biloxi and Jackson. So, and by U.S. Census data, the yellow is rural Mississippi. This is by the U.S. standards of Mississippi. So as you can tell, and then there's varying definitions of rural. So the light red areas of the map are considered quasi-urban or suburban, but the dark red are decidedly urban. But anyway you cut it, Mississippi is a very rural state, and most of the population, about 65% of the population, still lives in what would be considered a rural setting. So that's Mississippi. That's kind of the playing field, as it were, for us. So for the purposes of this talk, we're going to shift gears a little bit and talk about rare disorders for a few slides. I don't know to what extent everybody in the room is pardon me, aware of rare disorders and kind of where they fit into medicine these days, but we're going to talk about rare disorders almost as if they were the same thing as genetic disorders, although they're not. And kind of elucidate that definition a little bit in the next few slides. But I'm of the camp of geneticists who feel like what we do clinically is actually rare disease medicine. What we do is we try to diagnose and treat rare disorders in the genetics clinic. That's what we do as a clinical practice. So I'm going to use these terms interchangeably for the rest of the talk, but I want you to know up front that I know that there is a slight difference and that not all rare disorders are genetically determined disorders. But so what is rare disorder? So technical definition in the United States is any disorder, pardon me, where less than 200,000 people are affected. That's actually a pretty big number, and that doesn't, it's a pretty big disease. We're talking diabetes and asthma that have more than 200,000 affected people in the United States. There are others, obviously, but so rare disorders starts to open up into a lot of different disorders if we're considering that definition. But what that does is it shows us that rare disorders are not actually that uncommon. That about 10% of the population, or 1 in 9 individuals, are expected to be affected by a rare disorder by that definition. And like I alluded to before, that includes genetic and non-genetic disorders. Okay, so the genetic disorders we're talking about are the ones basically that are listed in OMEN, the online Mendelian Inheritance in Man database, which I'm sure most of you are familiar with and use. But rare disorders also take into account rare infections, rare rheumatologic, and rare immunologic disorders. Preparing this talk, the last count of Mendelian disorders in OMIM is 5,541. But as I like to tell my patients, that number is almost certainly going to grow and is growing. And since we have an estimated 25,000 genes or so, I'm sure that one can make an argument that there might be as many as 25,000 genetically determined disorders, give or take. the National Organization of Rare Disorders recognizes about currently 1,200 rare disease categories. So this is a big heterogeneous group of disorders that we responsible for, I feel, in genetic medicine. Just this slide is just to, we're not going to go through it, so don't worry, but it's just to show that the definition of rare disorders does change depending on where in the world you are. But the United States definition is a pretty good one at under 200,000, a disease that affects under 200,000 people. A good working definition is the last one, which is a disease uncommon enough that a general practitioner would not be expected to be familiar with it or how to treat it. That's a definition that Marshall Summer, my old boss at Children's National, liked to use for a rare disorder. And I think as a working definition, it's not a bad one. So again, rare disorders are expected to affect 10% of the population. That means 30 million Americans, and in my case, 300,000 Mississippians. I should have done the calculation for Georgia and Atlanta metropolitan area in particular, but you get the idea. 10% is an easy number to work with. Another number that a lot of people in genetics like to throw around was from Sean McCandless's paper in 2004 that looked at hospital admissions at Children's Hospital, I think it was Rainbow Babies in Ohio, and looked at what proportion of those hospital admissions were due to or in a patient with a genetically determined disorder. And the number they came up with was 34%, which is huge. I mean, that's, for those of us who are pediatricians doing rare disease medicine, that's, a big chunk. And I think that if you actually expand that out to include disorders that are genetically influenced, that number can rise to almost 80% of admissions to a children's hospital. Remember that we know that things like even asthma are genetically influenced disorders. Let's see. Yeah, and we had 8,500 admissions last year in Batson Children's Hospital. So that means technically we could have had up to 2,500 consults just from the hospital alone. And I like to think of that number as crazy because not one person can do 2,500 consults plus take care of all the outpatients in the clinic. But ideally, that's what we should be doing as rare disease clinicians and geneticists, is seeing all the patients with genetic disorders, right, and helping guide care and treatment. When my partners and the genetic counselors that left 2 years ago, we canceled almost 1,800 visits that were scheduled, and we actually had a 2-year waiting list at that point, which is not uncommon in a place with who's taking care of the whole state's worth of genetic disease. So I just I didn't want to leave you guys in suspense right away. From the beginning. So yeah, we have rebuilt over the last 2 years. We've done it in interesting and hopefully novel ways. But and I'm not going to go through all these people, individually. Maybe over the course of the talk, we'll talk about some of them and how they're helping patients with genetic disease in Mississippi. But this is just to say that we have rebuilt. A lot of people are part-time. There are a few of these people on this picture that are remote. There are people, we've hired our first, Leah Olweiler is our first completely remote genetic counselor, and Valerie Wadaker is our completely remote geneticist who's seeing patients in our outreach clinics that, they're seeing them from Ohio and Los Angeles without even living in Mississippi, but they're full-time faculty for us at the university. So, so that's already something a little bit different than what's the norm. So another concept of that's important to talk about when we're talking about rare disorders, that segues nicely into what it is that what I think a clinical geneticist does. and what we need to be able to do for our patients with rare disorders in the future. A helpful concept is the diagnostic odyssey, which most of us are familiar with. Diagnostic odyssey is usually brought up in the context of a painful experience for families. Sometimes it's even painful for providers, both primary care providers and specialists. So, and the diagnostic odyssey is basically that process by which a patient with a rare disorder gets diagnosed, and it encompasses the interval of time between the onset of symptoms all the way to the actual establishment of diagnosis. It includes not only the time that the patient is kind of wondering what's going on with them, or the parent of a patient in the terms of pediatric rare disorders. It also has to do with the time of that first interaction with the healthcare system, and then the specialist interactions that usually come later, which includes the geneticists like us. The unfortunate thing is that as long as we've known about the diagnostic odyssey, we haven't gotten that much better at closing the gap on how long this process takes. The latest averages from NORD and from the people that report on this stuff in the literature is about 5 years. 5 years from initial symptoms all the way to an established clinical diagnosis. That's a long time for a patient. That's a long time for a parent of a sick child. So one of the goals of clinical genetics or rare disease medicine as we move forward is figuring out how to make 5 years a lot shorter. And of course, you guys and us, we're all as a specialty doing much better with with thinking about this now that genetic testing is a little more ubiquitous and getting cheaper, as we'll talk about. But what are the problems with this diagnostic odyssey for rare disorders? They're not unknown to us, and they're myriad, and they kind of come at you from all different directions. I mean, diagnosing a rare disorder is difficult because of a lack of information and awareness. Sometimes the symptoms are all over the map. Depending on where you are, you may not have the right diagnostic tools or the right person, specialist, even PCP, to actually make the connections. Of course, minimal physician training in rare diseases and in genetic diseases, and poor communication amongst all of us. And of course, all of us have different health systems, that are just as complex as the next and don't work exactly the same. So, and this has been talked about a lot, the fact that if we're going to say that clinical geneticists are the ones that are, or medical geneticists are the ones that are at the forefront of this type of medicine, then, there's not enough of us. If you live in South Africa, there's one medical geneticist for 4.5 million people. That's a tough job. I wouldn't want that job. Like I said, here we started off in 2017. We had one geneticist for every 300,000 Mississippians, and that was a tough job. So, and it's not much better in the rest of the Western world either, where, one can talk about what we need to be doing as a field to attract younger people into it, but we may be stuck with what we have. So we may not have a choice in the matter of more geneticists. And this is a slide from my friend Sean Hoffer at GeneDx. A lot of what's driving rare disease medicine, I would say, at least in 2019, is the availability of cheaper and more ubiquitous genetic testing. Genetic testing is easier to get than ever. It's more comprehensive. It's more, obviously, with whole exome and whole genome technologies, it's more, it's casting wider nets. And, everybody in this room knows that, just around the corner is direct-to-consumer testing for a great number of things, including whole genome, whole exome testing. So this is just GeneDx's numbers over the last 6 years or so. And as you can say, their total volumes are just climbing and climbing and climbing. We use them as a reference lab here because we don't have our own genomics lab like you guys at Emory do. So we have to use a commercial provider, and we have, I guess for, conflict of interest statement, we do actually, the University of Mississippi has a contract with GeneDx and Mayo for a lot of their genetic testing. I use this slide, and I use GeneDx only because Sean's a friend and he was willing to provide their numbers to me. But as you can see from the pie graph too, there's plenty of diversity in the type of genetic testing that's sent to genetic testing labs too. So again, kind of a cross-section of the rare disorders that we're all taking care of these days. And so the rest of the talk, wow, it's already a half an hour in. I hope I'm not boring anybody, but the rest of the talk I was going to focus on what is it we actually do as medical geneticists, as rare disease specialists. And the core of it is actually we evaluate patients for the possibility or suspected rare genetic disorder. We arrange testing, we come up with a genetic testing strategy, and then once we hit on something, we make sure that they're counseled and treated. I didn't put treatment here just because for a vast majority of genetic disorders these days, we still don't have molecularly targeted treatment, right? Obviously that's changing, but that's not what we have. But a lot of times, if we hit on a diagnosis, or I shouldn't say, I said 99% of the times, we can provide counseling, education, which is a huge part of what we do. To explode this core of our practice a little bit more, to add suspicion at the beginning, and then the things that come from counseling at the end. This is a more honest model of what it is we do in clinical genetics. First, we have to suspect a disorder, right? And then we have to, or not just us, but somebody out there, out in the community has to suspect a disorder. And then it gets evaluated. And then we come up with a differential diagnosis and a genetic testing strategy. And if we're right, on to counseling, like I said. If we're not right, then back to the drawing board, differential diagnosis, this whole rinse, lather, repeat kind of, or lather, rinse, repeat, sorry, model that has been the hallmark of diagnosticians and rare disease clinicians for decades. And, if we do hit on a diagnosis after our clever evaluation, then we provide counseling, and a lot of times we can provide treatment or care coordination at least. We provide cascade testing to at-risk family members. We provide resources for patients, and we're going to talk a little bit more if we have time later about what I mean by all this. And then, of course, we link patients to ongoing research for the disorder that we've diagnosed them with, right? A very important part of our model and a very important part of our job is making sure that we know more about these rare disorders so that one day each one of them has molecularly targeted treatment. So, suspicion. This is where it starts with rare disorders. And I present to you a case of a 5-week-old girl with failure to thrive and vomiting. Family history, this is a first child for a non-consanguineous parentage, and mom has a history of very severe gastroesophageal reflux. She was actually had a Nissen when she was a baby and ended up with an esophageal band when she was a teenager, just trying to control her symptoms. She reports in the baby posturing that was almost thought to be seizure-like activity, and lethargy with all these vomiting episodes. And a PCP in North Mississippi had this child admitted and did the usual things for gastroesophageal reflux, but because of the history of lethargy and posturing, thought to do a lactate and ammonia, and found that the lactate was, and this was for those metabolic people out there, this was free-flowing, non-tourniqueted on ice and analyzed within 45 minutes, lactate and ammonia that were decidedly abnormal, and they were repeated and they were abnormal as well. I'm not going to lie to you. I don't have a punchline for this case because this is a real case that's kind of ongoing right now. We don't have a diagnosis, but what I loved about this case is that we're going to get to a diagnosis, I'm sure. But the outside pediatrician thought about pneumonia and a lactate with a child with lethargy. And so that suspicion of his led to this child being connected to a rare disease center like ours, whereas with a history of gastroesophageal reflux, had that person, that pediatrician, not been aware or had the suspicion of a rare metabolic disorder, those labs might not have ever been sent, those simple informative labs. So suspicion can come from anywhere, from primary care providers, specialists themselves, or other health-related professional. Everybody's had this situation where a physical therapist has said, I think that there's something a little bit more than just a mild gross motor delay going on here, as a way of connecting them to a rare disease or rare disease specialist or geneticist. But suspicion also comes from the community and comes from the patients themselves and the family members and from even teachers in the schools. And some of the things that I think drive that suspicion are education, training, and the professionals and paraprofessionals, but also awareness and education in our populace, and as well as the good luck of having the right person with the right awareness and education there at the right time. But we don't really like to rely on luck too much, right? So what do I mean by education and training? I mean, everybody who does genetics knows that not every doctor is educated the same when in terms of genetic disorders. And so I think that that's changing in some places. I know that here at the University of Mississippi, we've taken great pains to weave genetic disorders and genetic rare disorder training into the medical curriculum from first through the fourth year of medical school. I've always been impressed. I think it's been a decade now that Johns Hopkins actually turned their entire medical curriculum on its head and entitled it From Genes to Society, as a way of saying that the healthcare education or medical education should owes a lot to genetic medicine and needs to start with a firm understanding of genetics' role in health and disease, and then weave that through the different layers of disease and disorders all the way up to the macro interactions of interpersonal and social relationships. Those of you who know me or know my background know that I trained actually in genetics at Mount Sinai in New York and was there as junior faculty for a few years before I went to Children's National in Mississippi after that. But Kurt Hirschhorn, as in Wolf Hirschhorn 4p minus chromosomal disorder, was my program director and one of the most brilliant, interesting, clever thinkers that I've ever met. And he used to, some of the deceptively simple phrase that he used to talk about in terms of educating not only medical students, but also the residents in pediatrics and in genetics. He always used to say, you need to teach them how to think genetically. Like I said, a deceptively simple phrase, but something that what he meant by that was that we need to teach people how to always, with disease, whether it's asthma or whether it's Down syndrome or whether it's, cancer, we need to teach them how to think about the genetic basis or our knowledge of the genetic basis of those disorders or lack of knowledge of the genetic basis of those disorders when we're thinking about disease. And you'd be surprised at how many times when I'm talking, or any of us talk to a colleague about a particular disease entity, that what we're talking about, we're kind of up in a clinical definition of disease, and not really thinking down on the biochemical drivers of that disease, the biochemical and genetic drivers of those disease processes. So anyway, Barton Childs, another geneticist from Johns Hopkins, wrote a book, I guess it's almost 2 decades ago, called Genetic Medicine, A Logic of Disease. I encourage anybody to pick it up and read it, because I still think it's a very prescient, wonderful book about genetics' role in medicine as a whole, and kind of elucidates where we are in terms of medical genetics as a practice, as a subspecialty of medicine, versus genetics in medicine, which is how genetics and genetic thinking fits into all the other subspecialties that aren't rare disorders, how it fits into cardiology, how it fits into endocrinology, surgery, pediatric medicine, internal medicine, family medicine, all that sort of stuff. Obviously, genetics is, as a topic, is more ubiquitous. So, we need to know how it's going to fit into all these other specialties. And primary, secondary school education is the next topic I'll talk about, because that's an important part of not only how we educate our future doctors and geneticists, but also how we educate our population. So primary and secondary education, I think, I'll just kind of lay my cards on the table, I think is woefully under-organized and emphasized in our primary and secondary schools. The National Academies of Science, actually in 1996, had guidelines for standards for K through 12 of how we should be educating our students about genetics, and there were 9 mentions of the word genetics, and this was about the closest we got to genetic disorders was genetic predispositions and malfunctioning organs, health habits and environmental conditions as drivers of illness, and that was pretty good. That was in 1996. The academies looked at this again and published guidelines in 2012. Those are the latest guidelines that I'm aware of. They may be working on a revision now, but we were up to 51 mentions of genetics in 2012. Again, probably just 1 mention of health-related genetics, and most of it was about evolution and the life sciences and the gene's role in the cell. But we're getting there. Of course, genetics education in primary and secondary schools are largely run, not by the National Academies of Science and not at the federal level, but at the state and even at the school level. And there's a lot of variability in what our population, lay population is learning about genetics. And those of us who sit in genetics clinic know that. We know that, we have PhDs in genetics that come see us, and we have people who haven't heard of what DNA is and inheritance and how genetic traits are passed on through generations. So we need to do a better job at that. Suspicion for genetic disease also increasingly comes from advocacy organizations, both at the local, regional, and even the national level. Disease-specific ones like PKU Alliance, the CF Foundation, that sort of thing. And of course, the big umbrella organizations like NORD. I talk about the Diet Coke talk, but this is, I'm sure Ronnie will appreciate this, but I always, if I'm sitting in front of somebody who's drinking a Diet Coke, I almost invariably pick up the can, and whether they like it or not, they get a lecture on PKU and phenylalanine, and I don't know, it's like really a quirk of mine that I do, and most of the time they've never heard of it. Most of the time, it's an education to them, but I feel like I'm doing my small part in making sure that everybody knows what PKU is, and one rare disease, at least. So, I think as all these things become more harmonized, and as we put more effort into education, training, and awareness at all levels, I think that our luck with getting those who need evaluation for genetic disorders into the system will get better with time, if that makes sense. So, so this talk is longer than I expected it was going to be, probably because I like to ramble a lot. So I think I'm about halfway done with only 10 or 15 minutes left. So I'm going to, this is actually a topic, how trust with the medical system actually impacts people's access to the genetic system, I think is a big topic that actually, along with our diversity and group here at the University of Mississippi Medical Center, we're actually turning into a bigger lecture series on how aspects of trust of the medical system, especially in historically underrepresented minorities, how that actually impacts what we're doing here and trying to do with rare disorders. Because it's one thing for cisgendered white male to access the healthcare system and the rare disease evaluation, testing, and counseling system, but it's different for marginalized groups to do this. And trust is such a big part of what we do in genetics. If you don't have the trust of your patients and the patient's family, as somebody in my clinics likes to say, if grandma doesn't believe you and trust you, you're not making any headway with that family whatsoever, because it's just not going to happen. And we have real problems with trust in healthcare in general, but also historically with certain groups in this country, including African Americans, which is near and dear to our hearts in Mississippi. But this is a picture of President Clinton officially apologizing for the Tuskegee syphilis trials that were done with the support of the U.S. government. This wasn't until 1997 that he officially apologized, after this had been going on for 40 years. And this is Howard Shaw, one of the last surviving Tuskegee people who were involved in that whole, atrocity. And so African-American population in Mississippi and all over the country, but especially in the Deep South, has a deep distrust for healthcare systems, and that doesn't stop at the genetics clinic. So we have to really be cognizant of those historical missteps that medicine has done, and as we move forward. And the second picture is of Ethan Lindberger, who was this kid who, on his 18th birthday, ended up getting himself vaccinated after his parents, or his mother in particular, didn't want him vaccinated because of what she felt she knew about the dangers and risks of vaccination. And this was him testifying in front of Congress. The thing that what he wanted to get across was that, it was his decision to get vaccinated. And the most interesting thing he said to Congress was that the narratives and the stories that are being told by anti-vaccine advocates are more compelling than the stories that we're telling about vaccines as medical professionals and people who believe in vaccination campaigns. And I thought that was really an interesting insight that he made. So much so that I was just on a panel for personalized medicine here in Mississippi, and we were, I thought, having a very interesting discussion about personalized medicine and genetics and genomics' role in that. And then halfway through, a parent got up and derailed the entire conversation with comments about her distrust of vaccines. And that's where the conversation for the rest of the panel went, was vaccines. So it may seem kind of odd to put it in a talk about genetics and genetic medicine, but I think that gaining trust and gaining some sort of sway over the narrative is going to be important for us in rare diseases as well. So evaluation. In the last 15 minutes of this talk, I was going to tell you a little bit about what we're doing specifically here in Mississippi to make things a little a more interesting delivery model. Case number 2 is an 8-month-old boy was admitted to our PICU with new onset seizures. His weight and length were less than the 3rd percentile. He had a known VSD and ASD from early on in infancy, but he also had non-familial facial features that nobody had ever really thought to question. But because of this new onset seizures, one of the PICU attendings felt like, there's something going on here. Also, this PICU attending, who was very sensitive to situations like this, because she had actually trained with Marshall Summer at Vanderbilt, she actually knew to call us. So when we actually evaluated this child, it appeared that this child with a constellation of presenting symptoms as well as the non-familial facial features might actually have Wolf-Hirschhorn syndrome. This is again another case that's kind of in the works right now, but the reason I wanted you to hear about it is that I actually evaluated this patient completely over telemedicine, asynchronous, store and forward telemedicine. This patient was not evaluated by an in-person geneticist, partly because I wasn't in town when this consult came through, but partly because we've actually set up a model so that dysmorphic patients in the hospital with concern for a genetic syndrome were actually evaluated 90% of the time by a remote geneticist. In this case, it was Julie Kaplan, who's a dysmorphologist that used to work here, but she works at Nemours Children's Hospital now. She moved for family reasons, but she liked her job here so much, and I do mean that. She liked her job here that she wanted to keep some of her effort with us. So we went back and forth, and we finally figured it out. And so she actually does our dysmorphology consults from Delaware. And she diagnosed and did initial counseling with this family from Delaware. We actually use a model. I showed this because actually this is a model that we were working on at Children's National before I left. This was an app we actually developed with iLinks and Microsoft to do asynchronous mobile genetics consults. My understanding actually is that this technology is actually Marshall Summers using this technology now with international asynchronous telemedicine consults at Children's National. But I lost use of it when I left. Sad face for me. But the nice thing and the clever idea we came up with was to use the EMR that we have at the hospital, Epic, and its companion app on our iPhones and tablets, Haiku. We actually take high-definition pictures of these patients wherever they are in the hospital, in the children's hospital, and they're transmitted. Actually, they're not even transmitted. They pop up in the media tab of Epic. Do you guys use Epic at Emory? Or I know you have different hospitals that you guys work with, but I'm sure you...
Yeah, we have 2 different, and we have Epic in one of the main hospitals.
Great. So, so Epic has this capability and you guys are aware of it, I'm sure. But, and the nice thing about using Haiku is that none of these pictures stay on the photographer's device. So they go straight to the medical record under the media tab. And Julie examines these pictures and it decides whether or not, this patient might have a genetic disorder and what the genetic testing strategy should be. And then she actually follows these patients up when they're discharged in a synchronous telehealth clinic in our clinic. So to date, last year when we started this program, we've completed about 111 consults just by asynchronous telemedicine. We got a diagnostic rate of about 21% while they're in the NICU. So our diagnostic rates are better over the first year. I don't have that number for you guys, but during that first month or 2 that they're in the NICU, we get the diagnosis about 21% of the time from all different indications. This is a table of all the different reasons that they consult genetics, and we do these asynchronous consults. And this is a list of the 23 we've actually diagnosed in the NICU, or the PICU, I should say. This is the list of diagnoses. So you can see everything from, chromosomal aneuploidies to imprinting disorders like Beckwith-Wiedemann, and even some strange skeletal dysplasias and other genetic disorders. So just as a proof of principle, this kind of asynchronous telemedicine can work and deliver good care. We've done lots of satisfaction surveys for this service with parents and with the NICU staff and the PICU staff, and so far everybody really likes it. I mean, they get an answer within 24 hours. They're very happy with the support that they get. And when I say support, I mean, even though Julie, the clinical geneticist, is off-site, we have a nurse practitioner named Bethany Robinette, who actually is the boots on the ground for this particular service. She's the one that actually has been trained by our genetic counselors and myself to go get the family history, to meet the family, to talk to the family about what genetics does and what our evaluation will look like. And she's the friendly, grounded face that allows us to do this model and still provide kind of, traditional care, so to speak. So it's not just a disembodied robot that's doing your baby's consult, but also working as part of a team. And we came upon this solution in part because of nurse practitioner Bethany was gifted to us by my chair when everybody left, because she couldn't present the team with more geneticists because there weren't any to rustle out of the bushes. So, but nurse practitioners, as many of you may be aware, we're training more and more, or educating more and more nurse practitioners, and it's only going to become more over time. So we are very much a program that has embraced this and we have two nurse practitioners that work with our team, one on the metabolic side and one on the dysmorphology side. And we're integrating them into the team and getting them integrated nationally with the small group of nurse practitioners that are practicing genetics. I don't know if anybody there is aware, but there's the first annual, or the first ever, conference for advanced practice nurses in genetics is going to be going on in Milwaukee in the fall, and both of our nurse practitioners are going to that. So the three ways in which we've used advanced practice nurses is, like I told you, the Bethany is in the hospital doing consults along with Julie as the remote geneticist, but Bethany's also in the genetics clinic, and she runs something called our chromosome clinic, because a lot of kids with aneuploidies like Down syndrome and Klinefelter and Turner have guideline-based health supervision. Also, a lot of kids with even rarer chromosomal differences actually just need care coordination a lot of the time. So she works on her own, but with guidance and oversight from myself and the genetic counselors on care coordination for families with children with chromosomal differences. She also has another clinic that's devoted just to kids who are being referred by primary care providers with developmental concerns or autism. And the reason we can do that is because, of course, the ACMG has nice practice guidelines for those patients that she's able to follow. And anything that goes beyond these guidelines, she kicks up to me as a geneticist or one of our new telegeneticists. And of course, the model that a lot of people are used to with advanced practice nursing is the NP and metabolism clinic. And we have Misty Tharp, who does our newborn screening, first call. She does care coordination for patients with metabolic disorders, and she runs with me a small infusion program. So I think nurse practitioners, one of the challenges there is getting them integrated into the team, but also giving them some skin in the game so they feel invested and want to make a career out of genetics not just get the training and then go off to do, general practice again, but actually stick with it. And I believe in the model, and we've been working with it for the past 2 years. And testing is the next thing that we do, the next thing that as a clinical geneticist we need to be thinking about in terms of diagnosing patients. And this is going to be a short little section, I promise. But all of us have the situation where we have patients who have a working diagnosis of something that that ends up getting turned over in with whole exome sequencing, and that is the case with the 16-year-old boy who was living with pyruvate dehydrogenase complex deficiency because of a borderline enzyme assay when he was 2, but exome sequencing turned over his diagnosis, and we found that he actually had causative mutations in both OTS2 and TUB3. And this is going to happen more and more. Not only are we going to zero in on the real diagnosis soon, but we're going to be overturning working diagnoses for patients more and more. This is just how we've linked disease states or disorders with genes, and it's increasing over time. And this is that little orange box is the number of genetic disorders that actually have treatments. To put it another way, this is data from the FDA showing orphan drug approvals over the last few decades. And as you can see, we're getting more targeted treatments every day. So genetic testing in our evaluations are becoming more important so that we are linking patients to the correct treatments and to the correct clinical trials. It's long gone are the days where we can just expect that if we actually do head on a diagnosis, there's going to be no treatment and no cure. We can't be assured of that going forward for the next couple decades. There's going to be more and more treatments for these things. So, and the last topic we need to talk about is counseling, which I think, I apologize, I'm giving it short shrift in the last couple minutes of this talk, but counseling, I think, more and more and increasingly through my career, I think it's one of the most important things that we do as genetic service providers is give people good quality, balanced information about genetic diagnoses. Lord knows that the internet is not the place to get that information for the most part. And if it is, it's with a lot of guidance that ever happens. And proper counseling is what is the gateway to proper treatment and proper testing for the rest of the family and proper resources and connection to research, whether that's being done by a genetic counselor, that's being done by an MD geneticist, or as in our model, sometimes even with advanced practice nurse. Just quickly, this was a case of a 32-year-old woman with an APC mutation who was dying of colon cancer, and we counseled her about this change in her, and we counseled her whole family all over synchronous telemedicine on the coast. I mean, obviously a 3-hour trip to Jackson would have been a burden to this family. And we were able to provide telemedicine services to her and family. And I think it made all the difference in their counseling. We don't have time to go over all this. You already heard about me doing telemedicine from DC. I was just going to talk a little bit more about our telemedicine services here proper. And this is just a slide to say that we do pretty much everything now. We're doing synchronous telemedicine in 5 different clinics around the state. We do telemedicine in Tupelo, Meridian, Hattiesburg, and Biloxi. This is general genetics, this is metabolism, and this is straight genetic counseling as well. I told you about the asynchronous things that we're doing with dysmorphology. We've actually added a hospital on the coast. Gulfport Memorial is actually, we're doing asynchronous dysmorphology consults in their NICU as well. We're even developing a remote patient monitoring program with our PKU patients, much like the one that we have for our pediatric diabetic patients. And part of our telemedicine HRSA grant here, we're actually going to be doing home visits soon for our metabolic patients as well. From a counseling perspective, we are, and I know I'm running over, so I'm just going to the last 2 slides, because I think this is really neat too, because we don't want MD geneticists to be the bottleneck to patients being connected to good genetic services, we've actually started to embed our genetic counselors both electronically and in person into subspecialty parts of our children's hospital. So Leah Ohlweiler actually is developing an epilepsy genetics clinic with our pediatric epileptologist, and has developed a channelopathy or sudden cardiac death clinic with our pediatric cardiologists. And Erin McCown is actually working embedded in our pediatric cancer clinic, and is getting identifying and getting all of our hereditary cancer syndromes diagnosed in the cancer clinic. And so this is how we're kind of releasing genetic services out of the traditional division of medical genetics and allowing them to exist in the rest of the children's hospital. What's nice is that the genetic counselors come back to their nest, which is us, and we can provide further discussion and further ideas about the genetic diseases that they're seeing in these clinics. And then another important thing that I think that we're doing here is this is Braden West and Katriana Fields, who are both genetic counseling assistants that we have here in our division. This was a program that I fought hard to keep when in 2017, and I think is a great success. Both of them were selected out of a stack of candidates to work with us for a year or two while they apply for genetic counseling school. Actually, both of them I tried to convince to be MD geneticists, because I think they're both really bright and could have been MD PhDs and gone the end. But I was proud of them because they both sat me down and said, no, we want to be genetic counselors. That's what we want to do, and that's what our profession is going to be. So both of them are applying to, actually, Braden has been accepted to genetic counseling school in Arkansas and will start in the summer, and Katriana is in the process of applying this year. So we're trying to also home grow our genetic counselors for the future. So both of them have the intention of moving back to Mississippi to practice, and both of them we would be happy to have back as fully fledged genetic counselors when the time comes. So, and their positions will be backfilled, and we're hoping to continue this process throughout the next few years. We're doing something similar with our our genetics residency as well. We're starting to groom pediatric residents who want to stay in Mississippi to do training here, so that we can grow our own, so to speak. So so I've gone over, and I don't really need to talk about these last few slides because I've done it here and there. So I'll stop there, and thank you for your attention. And I thank you for sticking with me for these extra few minutes.